Hello, today's subject is the Nobel Prize in Physiology or Medicine from the year 1909, awarded to Emil Theodor Kocher for his work on the physiology, pathology and surgery of the thyroid gland. Here you see a child affected by a lack of iodine, which is due to malfunction of the thyroid gland, of course. Here you see the thyroid gland in the throat. Then we go to not his Nobel Prize lecture. He did have a Nobel Prize lecture, but it was very long. At least the text on the Nobel Prize site is very long. It is not original Nobel Prize lecture, but a longer text. The original seems to be lost. It is so long that I decided to take another text written by a Gemsenjäger concerning pathological manifestations in the low-grade thyroid diseases to deal with the subject. Not that the original text is not interesting, but as I said, it is very, very, very long. Okay, only the parts concerning the thyroid glands from the article mentioned are used. The others are not used. So also this is a summary, but it's, I think, about 90% of the original article. Well, total thyroidectomies, this is total removal of the thyroid gland, had also been performed by two surgeons from Geneva, Jean-Louis Revedin and his cousin Auguste, you can see when they lived. They had drawn Koch's attention to a post-operative condition they called myxodème opératoire. Subsequently, Kocher himself found this sequela in 30 of the first 100 patients he operated in this way. He coined the name cachexia strumipriva, I hope I say it correct, for this clinical consequence of total thyroidectomy. In 1983, he reported on a clinical picture and the possible causes at the German Congress of Surgery. It's difficult to understand that Kocher refused to acknowledge the merits of Revedin, although contests about priorities were as common at that time as they are today. Myxodème opératoire was the more adequate term. Revedin was aware of the disease myxodemia, which had been described as a corollary to atopic thyroiditis, this inflammatory disease of the thyroid gland, by William Orr and others, and became now the subject of a new evaluation by Myxodemia Committee of the Clinical Society of London. Orr exchanged letter with Kocher. The committee concluded that myxodemia as well as cachexia and cretinism were all a consequence of the deficiency of an unknown function of the thyroid gland. It was only years later that Kocher renamed his, between brackets, clinical picture, cachexia thyropriva. Kocher's work contributed a great deal to the growing understanding of the physiology of the thyroid gland, although not all of his days and conclusions turned out to be correct. So he insisted initially on the mechanistic view that the thyroid gland was an important regulator of blood flow to the organs of the neck and the brain. Equally unsuccessful was a search for isochemic tracheitis in the thyroidectomized patients, a task confided to his first assistant, César Roux, who later became full professor for surgery at the University of Lausanne. In 1893, Koch reported that patients suffering from cachexia strumipriva could be cured by the ingestion of raw thyroid from an animal source, a sandwich for breakfast as he proposed. This was shortly after George Murray had successfully introduced organotherapy to treat spontaneous myxodemia. In 1894, Paul von Bruns, you can see when they lived, between brackets, a surgeon in Tübingen reported on the shrinking of goiters with organotherapy, an observation first mentioned by a German psychiatrist, G. Reinhold, who administered thyroid organotherapy not only to myxodematists but to all mentally diseased patients, some of them with an incidental goiter. The finding of Bruns was confirmed by Kocher in 1895. Already in 1820, Condé in Genova had described the beneficial effects of iodine on goiter volume. Therefore, Kocher concluded that the iodine content of the ingested thyroid tissue was the active agent. However, his laboratory in Bern failed to prove the presence of iodine in the minced thyroid tissue. Careful clinical observations soon revealed that iodine and organotherapy were not efficient in all goiter patients. On the contrary, these therapeutic measures were prone to trigger a new complication, severe hyperthyroidism, particularly so in patients bearing huge goiters or those already suffering from Basedow's disease. For this reason, Kocher vigorously rejected indiscriminate use of iodine for goiter treatment. It is conceivable that Kocher's attitude delayed the use of iodine as a thyroid static agent in basis of disease until this treatment was reintroduced by Plummer in 1923. On a purely empirical basis, Kocher and Bruns chose either a conservative therapeutic approach, in modern terms a TSH suppressive therapy, or surgery to treat their goiter patients. We can only speculate today that the radical surgical approach was often necessary because of the presence, in many large goiters, of autonomously growing and autonomously hormone-secreting nodules or clusters of follicles. This indeed precludes any form of TSH suppressive therapy and even advocates pre-existing subclinical hyperthyroidism. The thyroid gland was the center of Kocher's interest up to the end of his life. In 1909, the Nobel Prize was bestowed on him as a reward for this work on thyroid and its diseases. In Kocher's clinic and his private practice, the impressive number of 7,052 goiter excisions were performed, 5,314 of which were done by Kocher himself. Still in 1930, the famous thyroidologist David Marine spent several weeks in Bern discussing thyroid problems with Kocher. And in 1917, a few weeks before his death, he gave a talk at the annual conference of Swiss surgeons addressing the difficult problem of the recurring endemic goiter after his presumable cure by surgical means. In this presentation, he mentions the efficacy of prophylactic iodine application to school children, but he failed to mention the impending beginning of goiter prophylaxis through iodine of table salt in Switzerland. Kocher in Bern, Wilhelm Helset in Baltimore, and Billrod's pupil Johann von Mikulitz in Krakow, Königsberg, and Breslau were at the time the leading representative of a physiological surgery based on a biological background. Mikulitz coined the term innere chirurgie, internal surgery. Kocher himself and his work had a considerable impact on surgery all over the world. On the one hand, he was acquainted with a large number of distinguished surgeons with and outside Europe, and he presided over many committees and scientific bodies, and he traveled a great deal. On the other hand, his reputation was spread by his pupils, among them César Roux, Fritz de Quervain, Carl Garay, you can see when they lived. A considerable number of male and female students from Russia visited Kocher University, between brackets, once the Bernese government voiced concern about the Slavic girls' school. Harvey Cushing spent several months with Kocher and subsequently developed his neurosurgical techniques on grounds of Kocher's particular surgical techniques. A large number of visitors, such as Wilhelm Halstead, George Crilly, Charles Mayo, René Leriche, and others, in addition to American surgeons with Swiss roots, such as Nicolas Sen, Henri Banga, Albert J. Auxerre, Martin Stamm, and others, acknowledged Kocher's influence on their work. One particular piece of acknowledgement came from northern Manchuria, where a volcano was named after Theodor Kocher. Not only did the Russian nobility send their sick relatives to Kocher, but even Lenin brought his wife, Nadezhda Konstantinova Krupskaya, to Bern to be operated by Kocher. Modern surgeons would attribute to the genius of Kocher two substantial lasting processes. First, Kocher had a kind of molecular vision when he empirically felt that the growth of goiter nodules is an early determined event in development and that normal thyroid tissue rarely, if ever, is the source of a goiter recurrence. In this way, he conceived the concept of autonomously growing, focally distributed cluster of follicular cells, and following this idea, he advocated the total and selective removal of all thyroid nodules, if necessary by total thyroidectomy, thus complete removal of the thyroid gland. All this was about 100 years before modern thyroidology, including molecular biology, basically confirmed his views. This Kocher and others had already realized that the so-called subtotal thyroidectomy, leaving behind naturally growth-prone tissue, would lead to goiter recurrence. He was also aware that most of these nodules could neither be prevented nor treated by any hormonal therapy, a fact that was definitely proven only in modern times. However, the high incidence of hyperthyroidism following radical extirpation of a goiter, a sequela realized in 1883 caused considerable alarm and even a kind of shock that persisted for decades, long after Kocher and until the second half of the 20th century. There's no doubt that the fear of hyperthyroidism was out of proportion to the clinical significance of this condition given the easily availability of thyroxine substitution. Nevertheless, this fear combined with the persistence of outdated surgical methods prevented the correct, that is, a selective surgery for a considerable time period. Then second, Koch's new operative style based on the precise identification of anatomical structures permitted the radical surgical removal of all diseased tissue with minimal morbidity. It's only around 1980, after the so-called method of subtotal thyroidectomy had been overcome, that Kocher's technique of capsular dissection was rediscovered. However, even today, not all thyroid surgeons are familiar with this technique. Koch's approach to the goiter surgery is an example of how the surgical technique largely determines the quality and the outcome of an operative procedure. Not unlike in other surgical domains, that is, such as in surgery of the rectum, it is the surgeon's technique of dissection which decides the appropriateness, the surgical morbidity, and the oncological outcome of the operations. The surgeon himself may represent a largely undefined compound prognostic variable. As said, this is not a complete article. If you want to read the complete article, you can follow this link. It will also be in the description of the video, as will be a link to the original, very long text of the, not the lecture, but larger than the lecture of Koch himself. Here you can see two pictures of a patient, one before treatment and one after treatment, and a second patient with the same. Here's a patient that had discontinued treatment for a time, and this is after treating again. This is, by the way, coming from the original Nobel Prize lecture by Kocher. Well, this is it for the moment. Next week, we will go to the Nobel Prize in Physiology or Medicine for the year 1910. Then we'll discuss the work, the biography, and the award ceremony speech, and the week after that, the Nobel Prize lecture of the year 1910 for this subject. For now, thank you for watching, and maybe until another time.